Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Sarah Anderson. This episode features content from an educational webinar titled Key Viral Hepatitis Studies Influencing My Practice Following AASLD 2021. During this podcast, Dr. Nancy Reau, Professor of Medicine and Chief, Section of Hepatology, and Associate Director, Solid Organ Transplantation, and Richard B. Capps Chair of Hepatology at Rush University Medical Center in Chicago, Illinois, discusses new viral hepatitis data, including studies related to hepatitis B, hepatitis C, and hepatitis Delta presented at AASLD 2021. For more information about Dr. Reau and for a link to the full online educational program, including downloadable slides, please visit the link in the show notes for this episode. Now, let's get started and hear what Dr. Reau has to say about new viral hepatitis data from AASLD 2021.
Thank you so much, Sarah. And thank you everyone for joining for this AASLD update. I think we were all hoping to have been in person and it was virtual. That's a good opportunity. If this program stimulates any interest, you can still register, or if you are already registered, you can view the presentations. They will be available until February. So just as a brief overview, I'm going to go through a little bit of data on hepatitis B. We're going to talk about Hep C, especially the Canadian Youth Care Cascade, and then we're going to cover hepatitis Delta, as D is definitely the less common of our viral hepatitises that we deal with. But because there's a lot of really exciting new development in this area, and it is a more virulent virus combination, we're excited to see some options. All right, so the first data that we're going to look at is the use of TAF in prevention of hepatitis B vertical transmission, or mother to childhood transmission. So as you're probably aware, TDF is the current recommended agent to help those highly viremic mothers in the end of their pregnancy to bring the viral load down and to prevent mother to childhood transmission. Entecavir is not advocated for, and TAF was really not advocated for because of lack of data. So this is one of the real world studies that's trying to accumulate the data that will hopefully lead to the assurance that this is also a safe option. The eligibility were maternal age greater than 20. It was anyone who presented at any pregnancy stage was eligible to participate. They could have either newly diagnosed active hepatitis B, or they could have been previously diagnosed. And they could have also been already on TDF, and there was an opportunity to switch from TAF to TDF or another regimen. And if you were not on TDF as a pregnant mother, we usually try to switch you anyway, as those other agents are not recommended as first-line treatment in pregnancy. Primary endpoints were maternal safety, infant safety, and then they also did some indices on head size and baby size at birth and 7 months, just to make sure that there was no other foreseen abnormality in the child. Secondary endpoints included the maternal rate of undetectable hepatitis B, and then infant really serology and markers at 7 months to really ensure that there was no maternal childhood transmission. So looking at maternal safety, you can see that there were about 200 individuals equally weighted between the TDF and the TAF arms. The pregnancy-associated nausea, anorexia, fatigue, and vomiting are well matched between the two arms. We don't really think that those are antiviral symptoms. Complications were also pretty equal among the two arms. We think that Hep B is a very well-tolerated condition during pregnancy, and so these complications are really on par for what you would expect to see in a general population. In some studies demonstrated a little bit more gestational hypertension and gestational diabetes in women with hepatitis B. This is not borne out in this study. So when we're looking at infant safety, here again, you can see that the amount of drug exposure, APGAR scores, congenital defects, as well as any other abnormal condition was well matched between the two groups. So there seemed to be no difference in any of these outcomes for tenofovir in the form of TAF compared to tenofovir in the form of TDF. Here we are looking at birth weight, head circumference, weight, broken down by both boys and girls. And you can see that between the two groups, TAF versus TDF, there were really no differences either at birth or at 7 months, suggesting that there was no impact on growth. Now, why would we even question this? there are data showing that TDF might have some, detriment in osteo or bone strength osteopenia, as well as renal insufficiency or renal function, although with a very short exposure that should be pretty small. But this confirms that there did not seem to be any growth abnormalities or differences between the TAF and the TDF group. So efficacy from a vertical transmission or mother to childhood transmission, there were no transmissions in either the TAF or the TDF group. This is really supporting the fact that TDF is first-line therapy for this highly viremic or 10 to the 10 times greater to 10 to the greater than 6 viral load. At that point, it is recommended to initiate antiviral therapy in the third trimester so that you can lower the amount of virus which decreases the chance that there's going to be escape from active passive immunization. Should also be pointed out that all the infants in the study did receive active and passive immunization. That would be standard of care. That's vaccination within 12 hours of birth, and as well as HBIG to prevent transmission. And there were no differences in maternal DNA level reduction or ALT normalization or E antigen seroconversion. We recognize that women do tend to seroconvert sometimes during pregnancy. And you can see that here with the 21 and 22% E antigen seroconversion in this group in the treatment naive individuals, and actually about a third even in the switchover or continuation group. So the key take-home points, there were no perinatal transmissions in either the TAF or the TDF group at 7 months, which confirms the fact that TDF is our standard of care and suggests that TAF is at least going to have the same degree of antiviral suppression and efficacy as TDF. Infants did receive standard passive active immunization, which is really important. This is not going to be a replacement for that. The TAF and the TDF groups did have similar efficacy and safety outcomes between baseline as well as postpartum month 18. And this really suggests that TAF might begin to play a role in the algorithm to prevent transmission from mother to child in those with active hepatitis B. But until then, our guidelines still do recommend tenofovir in the form of TDF. The next study that we're going to go through is RETRACT-B. This is a second presentation. There was a presentation at the AASLD meeting that looked at some of this data. So this is a build to this large cohort. This RETRACT-B is looking at nucleotide analog cessation in patients with chronic hepatitis B. This is a large retrospective cohort of 945 patients. This did look at the period of a year. So these individuals that were stopped on therapy were monitored for a year. And then most of this study looks at what happened to them after that first year of cessation. It's also really important to recognize that there were not defined stopping rules, nor were there defined initiation or retreatment rules, so that the individuals that stopped and started therapy was really at the discretion of the physician caring for them and not because of defined treatment endpoints. You can see the characteristics of the nearly 1,000 patients. They were predominantly Asian, but 9% were white. Hepatitis genotype B, further hepatitis B was the predominant genotype at 52%. The vast majority of the individuals were discontinued from either entecavir or tenofovir, but there were 9% that had received other therapies. The mean amount of duration was about 3 years, which would be standard if you're considering discontinuing treatment in a group that has not met some of those other more well-defined metrics. 84% were E antigen negative at the start. Now, that doesn't mean that they were E antigen negative at the time and they should have been E antigen negative at the time of treatment discontinuation. But some of the individuals were E antigen positive at treatment initiation. There were 11% that were cirrhotic, and the mean degree of surface antigen was 2.6 logs. And you can see that the rest of that many of them had abnormal liver enzymes, and there were about 9 visits per cohort. So when we look at outcomes, so the graphic on the left looks at what happened in that year, kind of that transition year when patients stopped therapy. There was a huge amount of virologic relapse as well as biochemical relapse. Virologic relapse is when the virus went up greater than 2,000 international units per milliliter. A biochemical relapse would be when the ALT went up 1.5 times the upper limit of normal. And then a clinical relapse is when both the hepatitis B DNA is elevated as well as the ALT. And so 57% had virologic relapse. Clinical relapse only occurred in 24%. That's expected, right? The virus starts replicating, then there's the opportunity to have an ALT increase. And so if treatment is reinitiated, or if they never had that ALT elevation, then there's going to be a lot less clinical relapse. It is important, though, that at least one or more relapse episode occurred in 66% of the patients. And so a fair number of them in that first year did have some form of relapse. When you look at the graphic here on the right-hand side, this shows that those that had sustained remission, so remember after that year and beyond, so that the graphic starts at 1 year post discontinuation and goes for up to 4 years after that, about 10% had a loss of surface antigen in the long term, and 20% had sustained virologic control. So 30% altogether had either sustained remission or surface antigen loss. So that would imply that 70% of this population did not have that. When we look at the factors that were associated with that sustained remission of surface antigen loss or virologic remission at 4 years, ethnicity was impactful. So the white patients did much better than the Asian patients. And if you concentrate on this middle line, which includes both sustained remission as well as surface antigen loss, which is probably the more important, you can see it was 48% versus 28% in the Asian population. If your E antigen was positive at the initiation of therapy, this also gave the opportunity for a little more control, 36 versus 28%. Although in those that started treatment at E antigen negative, 28% to have sustained remission is still pretty important. It suggests that not everyone, but a sizable minority still were able to come off therapy and have a sustained remission. Surface antigen levels at the time of cessation and commonly associated, and you can see this is also true here, 58% versus 24%, and those that had low levels of surface antigen. And then if you had a relapse in that first year, that was impactful. If there was no relapse, about 50% of them had sustained remission. Again, nowhere close to 100%, but 50%. Whereas in the 66% that had at least one episode of relapse in that first year, only 19% were able to have any kind of sustained remission. And then we're going to go through a little bit more of the granular data in a graphic form. And remember here, the differences between the virologic relapse, the 65% versus 44% are those that had 2,000 versus 20,000. So how much viral replication was occurring. And you can see if you look at that lower amount, the 2,000, 65% after 4 years had a virologic relapse. Biochemical relapse was much less. And if you look at something that we would consider more impactful, the red line here at greater than 2 times the upper limit of normal, that occurred in 43%, most of which you would expect should also be replicating. And then clinical relapse, which is both, occurred in 41%, confirming that it's that biochemical relapse that really starts to drive the definition of clinical relapse. And then 35% of individuals by year 4 were retreated. So that probably justifies the difference in clinical relapse and virologic relapse. And some of the individuals are going to be restarted on treatment before they had the opportunity to increase their ALT. So take-home points: sustained remission and Hep B surface antigen loss were uncommon after stopping therapy, even in well-suppressed patients, with 66% experiencing virologic relapse by year 4, and 66% having that early relapse episode in that first year. No relapse within the first year of therapy, discontinuation, white race, and E antigen positive at the treatment start, as well as low Hep B surface antigen titers were associated with sustained response. And unfortunately, most of the individuals involved in the study did have E antigen negativity at the time of treatment initiation. So, not to say that we should not learn our old therapies and how to use them best. So like the RETRACT-B study is trying to stop treatment in a subset of individuals that might be able to have a durable response off therapy. But this is a precursor of the incredible development in hepatitis B. You can see that there are multiple compounds here that were presented in abstract form, and many of these are in exciting new areas of Hep B control. We hope that some of them might actually even translate over to Delta management. And we suspect that you're going to have to combine these a little bit how we do hepatitis C therapy in order to have the ideal opportunity. But you can see that we have core inhibitors, that siRNA capsid assembly modulator, which is separate than other capsid assembly modulators. We have new nucleic acid polymers. We have a therapeutic vaccine. And then that there are single trigger RNA interference agents, which are really looking at strong impact on suppression of viral replication. So stay tuned. Hopefully, as we go through the next EASL and AASLD conferences, we will get even more exciting data that suggests that some of these agents might be headed towards regulatory approval, offering our patients functional or actual sterilizing opportunities for cure. All right, we're going to now move to hepatitis C. This is an interesting study looking at either children or youth. This was out of British Columbia in Canada, and they looked at nearly 1,800 antibody positive young people. Now, this is important because we know that hepatitis C is now bimodal. We do not diminish the effect in the birth cohort or those, at least in the US, that were born between 1945 and 1965. But because of the opioid epidemic, which impacts both women of childbearing age, which will go forward in maternal to childhood transmission, as well as young people that are injecting drugs or using drugs, that this is going to also increase hepatitis C incidence and prevalence in a much younger population. It's a nice time to put a plug in that we do have antiviral therapy that's approved all the way down to the age of 3, so that if you have a child that you want to treat, there are really excellent treatment options starting at 3 years of age. This, however, is looking at an entire cohort of individuals younger than 30, so 29 and below, and what happens to them as they're screened and attempt to navigate hepatitis C, the care cascade. So one of the very first things you can see here is that this 1,800 individuals, that those that received RNA testing were pretty small. So it went down from 1,800 to 1,110, and that's a lost opportunity. We now know that you can order an antibody that automatically reflexes to PCR so that it's a one stick for both the screening and the diagnostic test. So of those that did have RNA, 673 or 61% of the entire cohort was found to be RNA positive. And then of these, 80% were genotyped. This is important because if you're doing a genotype, even though it might be irrelevant for your treatment decision, it suggests that you're teeing someone up to be considered for treatment. The other surrogate that we sometimes will use is fibrosis testing, but in a group of individuals this young, they may not be thinking about advanced fibrosis. And so a genotype is really the test that's suggesting they're going to work with the payer to get approval for therapy. But of those that were genotyped, only 40% initiated treatment, and then 88% experienced SVR. It didn't say too much about where those patients went, if that was lost to follow-up, or if they were not adherent to treatment, as that's a much lower amount than what we would expect with some of our agents now. But it does show that there is a significant drop-off from antibody positivity to those that were able to achieve cure. So key take-home points, findings really revealed that there was a significant gap in hepatitis C therapy initiation, even though there were obviously other gaps along the care cascade. So it really emphasizes that there are likely barriers that make linkage to care of this population challenging, and that these have to be identified and addressed. And there were several, although not featured here, there were several abstracts presented at AASLD that address some of the creative ways to engage individuals that are still in high-risk psychosocial situations into therapy. So this Sarah Block actually presented a really nice reset. This is pre-pandemic data, so that the hepatitis C global status was recalculated to see what the impact of treatment was, so that they used mathematic modeling that was based on real data. Often it developed with the assistance of the actual country and the governing body. And those where they couldn't do that, they used other ways of trying to make their model. And they showed that in 2020, the prevalence for hepatitis C remained highest in Eastern Europe and Central Asia. Greater than 50% of the world's infections were in China, Pakistan, India, Russia, and the United States. However, greater than 10 million people did initiate direct-acting antiviral therapy between 2015 and the end of 2020. And more than a third of the individuals that initiated treatment were really in Egypt. So Egypt really showed as a superstar, as a place where there was a vast government and countrywide investment in identifying and linking patients to curative therapy. That was just a great success story. So in 2020, less than 25% of viremic infections were diagnosed and less than 10% initiated treatment worldwide, suggesting that even pre-pandemic, we had a lot of work to do. But the key take-home points for this is the global prevalence has declined since 2020, but 57 million individuals are still estimated to be viremic, so we still have a lot of work to do. Lack of screening and then subsequent diagnosis is still one of the largest barriers, although we could see from the Canadian study before that even initiation of treatment in those that are identified as having Hep C is lackluster. And so we have a lot of things along the care cascade to address in order to lead to worldwide elimination. All right, the last topic that we're going to move towards is hepatitis D, Delta. And this is something that we don't usually talk about because we're really seeing a lot of new opportunity for treatment of this group. There were several studies, and we're going to walk through a couple of those. So this is beyond CATU, which looked at bulevirtide plus pegylated interferon alpha for chronic delta, and this is plus minus. So you can see that there were two arms here, either bulevirtide 2 milligrams sub-Q once a day for a year, or bulevirtide sub-Q with pegylated interferon alpha 2A for 12 months. This was a compassionate use study. So this was every patient in this study had either well-compensated cirrhosis, because remember, you can't use interferon in a poorly compensated individual, or they had F3 fibrosis, or they had less degrees of fibrosis, but persistently elevated ALT for the 6 months prior to initiation. And this did involve 145 patients. Endpoints were virologic efficacy, which was defined as a hepatitis D RNA that was either undetectable or had decreased by at least 2 logs from baseline. And then biochemical efficacy, which was normalization of ALT, defined here as less than 40 international units per liter. This is the data looking at the time course across the year, so that the patients were monitored pretty frequently in the first 3 months, and then those visits were spread out. And you can see that either in bulevirtide monotherapy, which is the middle line, or in combination therapy, which is the far right line, that you started to see antiviral efficacy, because here we're looking at that decrease by 2 logs at least, or undetectable hepatitis delta RNA. And you could start to see that really kick in as soon as 1 month in the combination therapy and closer to 3 months in the monotherapy. And by the end of the year, combination bulevirtide and pegylated interferon alpha 2A managed to hit this virologic endpoint in 93.9%. So only 2 individuals that were followed to this time point had not achieved that. And that's compared to 68% in the monotherapy arm, which is still not anything to be frowned upon. That's still great efficacy. When we look at ALT normalization, though, there was a discrepancy. So it was much more frequent to improve your ALT on bulevirtide monotherapy than pegylated interferon in combination. And this was felt to probably be related to the PEG therapy itself, because it did not correlate to those that had suppressed their delta RNA. When we consider adverse events, so you can imagine that an interferon-based therapy is going to have a lot more adverse events, and you can see that any adverse event was 43% in the combination opposed to 29% in the monotherapy, but grade 3 to 4 adverse events were equally matched, 7 patients and 6 patients along the 2 arm. And discontinuations due to adverse events were actually very rare, 2 patients in one and 3 in the other. There were a handful of liver-related adverse events, slightly more in the bulevirtide arm, but this was not felt to be statistically significant. And there were very few injection site reactions, so the therapy was actually very well tolerated. Now, bulevirtide is associated with an asymptomatic increase in bile acids. And you can see this occurred in about most of the patients, 76 out of the 77 in monotherapy and 68 out of 68 in the combination. So nearly all patients had that increase in bile acids, which we've actually known about, and there was no deaths. All right, so key take-home points on this study: bulevirtide plus or minus pegylated interferon alpha 2A was safe and effective in achieving hepatitis delta viral suppression. Virologic suppression was more common in the combination therapy group, but ALT normalization was a slightly less common when you added pegylated interferon. All right, so we're now going to look at a different study. This is a study that looked at either high or low dose bulevirtide in patients. And it's important here to look at the study schema. There was a group of individuals who had a placebo lead in, and then were given bulevirtide 10 milligrams sub-Q daily for the last half of the study, compared to either 2 milligram monotherapy for the entire 144 weeks or 10 milligram monotherapy for the entire 144 weeks. This was also a really nice analysis. And not only did they look at the primary endpoint, which is combined undetectable delta RNA, or a decrease by at least 2 logs from baseline, as well as normalization of ALT at week 48, but they also obtained core liver biopsies in a subgroup of patients from baseline as well as week 48. And they used that to detect antiviral efficacy. So when we're looking at the no treatment, 2 milligrams or 10 milligram arms, you can see very easily that no treatment underperformed compared to the other two. 10 milligram compared to 2 milligrams was not dose responsive, which means that the 2 milligrams actually performed essentially the same as the 10 milligram. And you can see that of these individuals, that the median change of hepatitis D antigen from week 0 to 48 was about the same between the two arms. The number of patients that had undetectable Hep D antigen was about the same between the two arms. There was a slight increase in the 10 milligram arm for those that achieved undetectable delta RNA. But when you looked at the mean change by log, it is about the same between the two arms. It's also very nice to know that the intrahepatic hepatitis D viral RNA levels correlated strongly with the number of hepatitis D antigen positive cells and the hepatitis D RNA. So what they saw in the tissue looked like it was very nicely correlated with the surrogates that we can get from serum. So sometimes we find that the blood looks good, but the actual tissue is only demonstrating the blood levels are half the story. That was not true here. So the study also looked at some other inflammatory markers. So you can see that they looked at levels of CXCL10, which is an inflammatory cytokine. They also looked at other interferon stimulating genes, and that they demonstrated that bulevirtide reduced expression of these interferon stimulating genes, as well as the level of the inflammatory chemokines and cytokines, suggesting that if you can control or if you can decrease the delta RNA, that's going to lead to less inflammation and hopefully less fibrosis and progression in those individuals with hepatitis B and D delta co-infection. So the take-home points here: intrahepatic hepatitis D virus RNA levels were significantly decreased at week 48 with bulevirtide treatment versus none. That was true with both the 10 as well as the 2 milligrams. More than 33% of the bulevirtide treated patients achieved undetectable RNA, which is very exciting. And do know, though, from our other study that if they had combined it with pegylated interferon, it probably would have been a little more robust. The number of delta antigen positive hepatocytes significantly declined by week 48 with bulevirtide treatment versus none, suggesting that the surrogates in the serum reflect what's going on in the tissue. And about 50% of bulevirtide treated patients achieved undetectable delta antigen levels, which is also really exciting. This did translate to reduction in liver inflammation related to a reduction in delta infection. All right. Now, the last two studies I'm going to go through pretty quickly because I know we want to have a little time for questions. And this is really looking at a number of database claims or large data cohorts to give us a characteristic understanding of what delta looks like in the US. And so the first study was from Dr. Gish. And some of the important things here, and this is using a US claims database analysis, is that this population is young. They looked at anyone that had a hepatitis B or D, ICD-9 or 10 code, and then they looked for those that had delta on top of hepatitis B. And those that had delta infection really concentrated in this young demographic. And this is important because as this group of individuals is at higher risk for more severe outcome and liver cancer, this is going to be more impactful as it's a young population often working. And so it's really important to know that this is why we need to screen for this. There's also significant geographic variability, and maybe delta has a soft spot in myself because Illinois has some of the highest delta rates across the United States. And so that you can see that there is significant regional variation, which means that we can target screening by region, concentrating in those places where we expect to see the most delta. Across the US, though, there was still a prevalence of 11.2% among those that were hepatitis B infected really emphasizing that we should be screening for co-infection because there are a lot of individuals out there with co-infection. Now, this was a different study, also from a US claims database, looking at disease severity as well as the type of insurance. And you can see here again, emphasizing that there is a young population with Delta infection compared to mono infection. And this was significant. The Hep B mono infected were a little bit older. The insurance type here, also the majority are going to be commercial, but there were differences that there was a little more Medicaid in the hepatitis D co-infected group. When we look at comorbid conditions or liver-related morbidity and mortality, there is a significant increase in Delta infection. This includes things that are common medical conditions like hypertension, but also other comorbid conditions like smoking, substance abuse, alcohol abuse. And remember, the risk for Delta, some of it is going to be just geographic. There are places like Romania, Russia, Mongolia, where there's going to be a lot more Delta, which might be from maternal to childhood transmission. But we also see Delta in injection drug use. And so this is emphasizing that the population does sometimes have some psychosocial barriers. Did see a fair amount of hepatitis C co-infection with both groups, although it was statistically significant to be higher, and a lot more HIV co-infection. Decompensated cirrhosis was also a little bit more common, although cirrhosis itself was about the same between the two cohorts. And there was also an increased signal in both liver transplantation as well as liver cancer, as you would expect if there are a young group of individuals with decompensated cirrhosis and cancer concentrating in them. So the take-home points here are really that patients with Delta have a significantly higher risk of liver disease, increased rates from comorbid conditions as well as liver-related morbidity and probably mortality than those that have Hep B monoinfection, and that the characterization of the population really highlights that we should be screening for this and linking them to care. With this young demographic, we want to make sure that we mitigate disease progression. And the studies that we presented before really show that we are going to have some agents to help us accomplish that. All right, so I know that I didn't give you a lot of time for Q&A. I'm happy to stay for a little bit over if you are. And Sarah, I think you're going to give me some questions. Is that correct?
That is correct. And thank you, Dr. Reau, for that excellent presentation and being giving of your time to stay for a few minutes over, because we've had a number of questions come in through the chat box, and we'll get to as many as we can in the next few minutes. So the first question links back to the pregnancy study in those mothers with hepatitis B. And David wants to know if you think there will be similar trials with the use of entecavir in this population.
So thank you, David. That's a great question. The answer is no, because there was some data, mostly from animal models, that suggested that entecavir might have some impact on development, fetal development. And because of that, entecavir is recommended not to be used during pregnancy. Also, because entecavir is not part of our HIV therapy, there won't be that HIV cohort that adds credible data onto safety. So I think that tenofovir in either the form of TDF or TAF are going to remain the most common. We can still use telbivudine or Viriad, so that there are other agents if you really can't get access to tenofovir.
Great. Thank you for reinforcing what we do in our pregnant patients for treatment. So with relation to that same study in the pregnancy TDF and TAF study, Susan asks the question, was weight gain in the women or the infant weight at birth compared, thinking that in our HIV population, TAF is associated with more weight gain than TDF?
You know, they did not report on that I remember. And since it's such a small period of exposure, usually just in the last trimester, that might not have been enough time to see weight gain. Also, I think it's hard when you're looking at that small number of patients to understand what is pregnancy appropriate weight gain, and if that would be enough patients to even show a true difference in weight gain. But I did not see that reported in the study.
Great. Thank you for clarifying that. We have a question from Mubin who asked, and this was at the very beginning of the presentation, about hepatitis B, and wondering if treatment strategies for hepatitis B in patients with low viral loads, so those less than 2,000, and mild elevations in ALT is ready for prime time as a standard of care.
Yeah, so I think that's also an excellent question. As we move towards the opportunity for functional cure, we start to redefine who's a good candidate for hepatitis B therapy. And here we start to recognize age. So if you have someone who's got a very low viral load and they're young, you might look for other reasons for the abnormal ALT as opposed to blaming the hepatitis B right off the bat. But as you start to get to be 35 or 45 in that window, both the AASLD as well as the European guidelines suggest that you might want to actually think of treatment, both for what we would have defined as an immune tolerant group, as well as someone that has viral replication with abnormal liver enzymes, because we do know that that one blood test may not actually represent what's happening to the patient if we would manage to draw their blood every single day. And so it's really going to be that it's gray, the recommendation, allowing the practitioner to be more aggressive if they would want to, but also not mandating therapy for someone who may not be ready to initiate treatment.
Great. Thank you for answering that question as well. I thought we had a great comment from Michael, who said at the present time, don't stop nuke therapy. I think this was related back to the RETRACT-B study. And yes. I wondered if you wanted to comment on that and maybe share your thoughts on treatment cessation in this population.
Yeah, so there's certainly a group of individuals that stops treatment against the advice of their physician. I think that one of the most important messages, if you have someone who's had durable long-term suppression and you think that you want to stop, you have to recognize that you need to have intensive monitoring, not even just in the first year, right? So probably beyond the first year, because there is a significant risk for clinically relevant relapse. And I think that we would never recommend discontinuing treatment in someone who's got cirrhosis, even though that group, that demographic was included in this study. Certainly those that meet the more traditional endpoint, so E antigen seroconversion, gives you a little bit more reassurance that you're going to have a better opportunity for sustained remission. But sometimes there are just patients that want to stop or want to have an attempt to discontinue their treatment. And as long as you have a good plan for when and how you're going to monitor them and when and how you're going to reinitiate treatment if necessary, that's the most important thing. But yes, it's not for the faint of heart.
Wonderful. Thank you for sharing your thoughts on that and the data on that. So I think we'll end with our last question related to hepatitis delta. And so Robert asked, and this was related to the CATU study, that if you split out the patients with undetectable versus suppression of viral load, what was the response rate to bulevirtide there?
So that is a great study. I mean, a great question. And I unfortunately looked at way too many bulevirtide data points to know that right off the bat. I think that there's a group that does suppress virus completely. It is much more common in the in the PEG plus bulevirtide arms. In the bulevirtide monotherapy, there is a smaller chance that you're going to fully suppress virus. And they did look at that composite of both lowering by at least 2 logs or loss completely undetectable RNA. And the differences were also a little bit different across the many studies. So some had a little more robust antiviral treatment and some a little bit less. That might have been related to some of the demographics of the patients themselves. But most patients will hit that 2 log decline. Most patients will not become completely undetectable. But many of these studies, they haven't captured all the patients. So some of it is just that they have 50 of the 100 patients actually at that endpoint. And I don't think that there's a discontinuation attempt. So many of these individuals will hit that end. And then, if appropriate, and that's a good decision with both patient and provider, will continue going. Bulevirtide is really being considered a long-term treatment option.
Thank you very much to Dr. Reau, and thank you to our listeners for joining in. As a reminder, to view the full AASLD 2021 conference coverage program on the Clinical Care Options website, click on the link in the show notes for this episode. And please be sure to check back regularly for more episodes on important infectious disease topics. Thank you.